All right, so talking about some treatment algorithms and how we're going to target some therapy, right? So, if we're treating major depressive disorder, we want to think about the severity and how many episodes. But in general, first they're presenting with a first episode, maybe in the moderate category, we can do a medication plus or minus psychotherapy. There's not a lot of data to say that the combination for those types of individuals of psychotherapy plus a medication is more beneficial, but certainly one or the other can be really helpful for people. We're going to treat them with a titration to get to a therapeutic dose if we use a pharmacological intervention, which can include these guys, right? So SSRI, vilazodone, vortioxetine, trazodone, NASA, NDRI, SNRI. So these are all potentially appropriate options for people. We want to get them to an appropriate therapeutic dose and then monitor for response. So if they don't respond, first question I always ask is, did you take the medicine? Did you take more than one dose of the medicine? Because some people will take a single dose, didn't work, they stop, right? So we'll assess for adherence and consider changing the agent to another product within even that initial space here. After that, we can start to get into more of the combining medications, considering our second generation antipsychotics, considering some of our older medications that have a bit more risk associated with them, such as tricyclic antidepressants for really severe depression, potentially ECT. Once someone has responded to treatment, it's appropriate to consider their continuation or maintenance phase. For first 1 to 2 episodes, 6 months or more is a totally appropriate way to approach treatment. However, people who've had 3 or more episodes of major depressive disorder are over 90% likely to experience an additional episode, particularly without treatment. So for those individuals, we will generally recommend continuing medications or intense, frequent psychotherapy indefinitely because their risk is much higher. However, half of people who have a major depressive episode may never experience another episode. So things we want to do, we want to follow up ideally every 1 to 2 weeks, typically monthly, and then have those trials. Now for maintenance, it's 6 months for depression, but 12 months or more a lot of times for our anxiety type illnesses. So we want to really treat them for a year or more if it's anxiety because of that lack of predictability. The nature of anxiety and its treatment tends to be a little bit different from that sense. So if we're looking at generalized anxiety or panic disorder, we're going to be starting an SSRI or SNRI. Psychotherapy is great here as well, plus or minus a benzodiazepine. So crisis level, severe anxiety, we would consider benzodiazepine. If they don't respond well, we can switch within that, and then we can start considering our antipsychotics group. We can do buspirone, hydroxyzine, a benzodiazepine, and consider some of our other alternative anticonvulsants such as pregabalin. Once they do well, 12 months. Okay. Now, for panic disorder, some people will benefit from a scheduled benzodiazepine because treatment of a panic attack is really difficult with a benzo, whereas prevention can be much more beneficial for people. So we will sometimes take that into consideration. For PTSD, we don't use benzos. Benzos do not help with PTSD. They actually can be disruptive in treatment. They don't allow people to process their traumatic memories, which can result in actually potentially worsening of core symptoms. So benzodiazepines, if we're primary treatment is PTSD, are not appropriate. Do not use benzodiazepines in that population. Sometimes PTSD, they are not even ready to think about treating their PTSD because they've got other conditions going on that we need to address. And sometimes we might consider a benzodiazepine in that case. Maybe they have bipolar and PTSD and they're not sleeping and they're agitated. Maybe we would use benzodiazepine there. But if our primary condition that we're targeting is PTSD, not appropriate. So with PTSD, we would use an SSRI first line. So the biggest ones are fluoxetine, paroxetine, or sertraline. For you guys, antidepressant, right? SSRI. If they don't do well with that, we can switch to a venlafaxine or another SSRI, and then we can move into quetiapine, which is Seroquel, or risperidone. So there is some data for some of the second generation antipsychotics for benefit here. And then lower down the line, then we start to reach for some miscellaneous antidepressants, tricyclic, MAOI. 6 months or more is usually appropriate. Again, it's totally reasonable to go 12 months plus for this type of illness. The guidelines don't have a consistent recommendation for how long to treat pharmacologically, and they really do stress non-pharmacological treatment with things like EMDR, for example. But someone has to be in a good space to do that. For OCD, psychotherapy, or a moderate dose SSRI. So again, they oftentimes will need slightly higher doses of our SSRIs in order to respond appropriately, up to 12 weeks. Then we would consider switching. After that, after we've tried the 2 SSRIs, so you see the theme for 2 SSRIs, then we would consider venlafaxine, clomipramine, which is a tricyclic but can be beneficial in OCD, despite its increased side effect profile. After that, we can think about antipsychotics, psychotherapy, which really is at the top, but we can combine them later on down the line. Glutamatergic, so something like a lamotrigine, for example, and go from there. Benzodiazepines don't worsen OCD, but they tend to not be really helpful for OCD. So if we're solo treating OCD, we typically won't use benzodiazepines. So to summarize our treatment algorithms, depression, if we're thinking about depression, the things we're going to consider, right? How debilitating it can be for individuals in the United States. SSRIs are first line, but we want to think about our patient-specific factors. So we can totally use an SNRI, mirtazapine, bupropion, etc. first line if it's appropriate, if there's a compelling reason to do that. So that could be side effect profile, their history, how close family members did on certain medications, what other conditions they have. And multiple trials and augmentation can be necessary, right? So we're looking at a little bit less than a coin flip for that first treatment of depression. And then it gets even harder to find a good medication for people after that. For anxiety, we can treat fairly similar to depression. For generalized anxiety, we're going to use those lower doses, titrate more slowly. Benzodiazepines have very specific roles in different conditions. So panic, generalized anxiety, if it's significantly severe, we can consider benzodiazepines. We would avoid benzodiazepines in PTSD because it's relatively contraindicated. And OCD, it's not super beneficial. If someone is using benzodiazepines, we want to make sure that we are considering the appropriate tapering and titration for those medications to try to prevent significant withdrawal effects. That's all I got for you guys. Thank you so much for listening. I hope you learned things. Take care. Bye.